Kia ora and welcome from Endometriosis New Zealand. I'm Deborah Bush, I'm Chief Executive of the organisation, and we're absolutely thrilled to bring you our March social media campaign. Why March? Because it's International Endometriosis Awareness Month. As part of our campaign, we've got some video clips, some newsy bits, and something special just for you. So make sure that you keep following us through March and share because you'll want to check that out and see what it's all about. Today, we're going to be interviewing Mr. Michael East, and as well, throughout the month, Dr. Fiona Connell from Auckland and Professor Neil Johnson from Auckland also. Michael is a gynaecologist, an advanced laparoscopic surgeon, and a doctor who believes in a multidisciplinary approach to the treatment and management of endometriosis. Michael is going to be answering the questions that you have asked on social media or private message, and we've asked him to really concentrate this morning on surgery. So if you asked a question about surgery, we've tried to incorporate that in our list of things to ask. In a moment, I'm going to be hopping out of this hot seat and popping round the other side of the table, and I'll be conducting the interview from there so that you'll hear my voice, but you'll see Michael and be able to engage with him as he answers your questions.
I have to say, gosh, this seat's hot. Thanks for warming it. Thanks for warming it up for me, Deborah.
Michael, welcome to the hot seat.
Thank you.
It's great to have you here, and we'll get straight underway with the questions that women have asked. Look, the first question coming up is, why do women get endometriosis? I have it, and only one of my 3 daughters have it. What are the genetic implications with it?
Right, well, as many of you will probably already know, about 10% of women in the reproductive age band have endometriosis. But if you have a first-degree family member, that's mum or a sister with endometriosis, then you've got about a 50% chance of having it as well. There's definitely a genetic thing going on. Now, genes aren't quite as simple as I have a gene for this, I will get that. Genes interact with our environment, and sometimes many genes together combine to produce an effect, i.e. endometriosis, and there are a number of genes linked with endometriosis. But they also interplay with the environment, and so they're not always fully expressed. And we don't even know what all those things are in the environment. We have an idea about some of them, but there's no doubt that some people, for example, you can have identical twins. They're genetically identical, and one may have endometriosis or be troubled by symptoms of endometriosis, and the other may not, which means they haven't got endo or they're not getting the trouble of pain with endo. So it's quite variable. We definitely think there's a genetic link, but we know there are environmental factors that make that genetic predisposition be manifested.
Thanks very much. I think that's a super answer. Look, the next question says, we hear a lot about early intervention. Why is this important, and does it mean surgery?
Well, it doesn't always mean surgery, and in fact, if you look at the total number of people that would be suffering from endometriosis, then it's going to be very difficult to get surgery as an option to all of them. We know that endometriosis can develop over the years, starting from the onset of periods up until right through until menopause, in fact. If you look at the different stages of endometriosis, of which there are 4 that are most commonly used in the most common classification, the earlier stages, the disease is relatively superficial within the pelvis, not having burrowed into deeper tissues. And those earlier stages are more common in younger women, which, as you would imagine. And so the earlier you manage to see someone and get treatment started, be it medical treatment or be it surgical treatment, then you have more chance of influencing the outcome, where it's going to go in terms of how much pain it's going to cause, what fertility issues it's going to cause. So, yeah, we like to get in there early because The other question you asked, though, was it always going to cause a need for surgery or bring about a need for surgery?
Yes.
It is one of the better managements, there's no doubt about that, but it is not the only way to go. And I certainly have a preference for using progesterone-only medications rather than the combined pill, for example, in trying to contain or hold the progression of endometriosis.
Well, particularly in very, youngsters. But you've been very supportive and seen quite a trend of increase in, just really following on from our discussion about this, in youngsters presenting with symptoms because of the education program we have running here in schools.
Yeah. So it's been, how long has it been going now in Canterbury?
It's been
about
20
15
years.
20 years.
20
right,
years,
okay.
yeah.
Well, I certainly graphed between 2001 and 2014 it was, looking at my own practice as to the percentage of different stages that I see. So you should expect stage 1 and stage 2 to be pretty flat, the same number roughly coming every year, because that's the entry point, if you like, in terms of diagnosis. But stage 3 and 4, which we know tends to develop over time, then if you can get in early and it does influence the rate of progression of disease, then you would expect a trend down. Now, this is looking at my own practice, and so it's not indicative of the whole of Canterbury. I can't necessarily extrapolate that out, but it is interesting to show that the number of cases that I need to operate on of stage 3 and 4 disease has trended down over that 14 years that I was graphing it. So, for example, in 2002, I operated on 32 women with stage 4 disease. In 2014, it was 9. So that's quite a trend down,
Yes.
and those are the surgeries we'd like not to do. We want to do the...
But the trend up in terms of much younger women presenting and teenage girls.
Yeah, well, that's
who
the
are
thing
still
that
at school.
parallels that
Yes.
trend, if you like, is if you look at the different pie graphs over the years in terms of age bands, then a higher proportion of women coming forward are younger. So the two things fit together.
So absolutely. So we can say that early intervention is really good if we've got an informed young population. So the third question really is, what is the best surgery for endometriosis?
Well, first of all, you've got to look inside, diagnose it and see it. We carry straight on usually to treat the endometriosis, and the best way of treating it is to remove the disease, excise it. Now, that's why we like to see the disease at an early stage, stage 1 or 2, because it is confined to the internal skin of the abdomen and pelvis, called the peritoneum, which looks more like glad wrap than skin. And it's a very thin membrane that we can very carefully dissect off and be fairly confident that we've got rid of everything that we can see. Ditherming or burning endometriosis is really taking a weed eater to it. It lops off the top and you've left the roots behind and it comes back. It's very hard to prove that in studies because, well, studies are studies and they don't always, you end up with a grey goo sometimes. But all those that are actively involved in surgery for endometriosis, I'd say that just about everyone would say excision is superior to diathermy or laser treatment.
That would be true really when we're talking about a general gynecologist as opposed to someone like yourself who is an advanced laparoscopic surgeon. Would that be?
Well, yeah. I mean, look, I do think that excising stage 1 and stage 2 disease can very safely be done within the province of a gynecologist who doesn't necessarily have advanced laparoscopic skills to the highest level, but they have got to have made a bit of an interest, taken a bit of time to perfect even those skills, but they are definitely attainable for the vast majority of surgeons doing laparoscopic surgery if that's what they choose to do. But stage 3 and 4 disease is a quantum leap again in terms of skill set, and really quite a lot more specific training should be undertaken before delving into deeper tissues within the pelvis, because the surgery becomes a lot more hazardous and difficult to do.
Absolutely.
And it's often, as you've heard me say before, Deborah, it's the sins of omission. It's what you leave behind that causes the problem. It can be what you do in terms of injury during surgery, but it's we want to not do a half-pie job. If we're going to remove endo, we want to remove it. And when it's infiltrating deep disease, then it is harder to remove. We don't want to just stop shy of removing it all because we're a little bit worried about what we're doing.
Absolutely, and I think your this conversation flows really well into the next question, which says that no one at my hospital excises the endometriosis. It's so frustrating and it's so upsetting that I can't get the surgery I badly want and that I badly need. What do you recommend that I do next?
Yeah, first of all, it's very difficult to criticise a surgeon working within their own safety comfort zone, because the most important thing when performing surgery is follow the dictum, first do no harm. And if that means that the safest thing to do for that surgeon is to diathermy the disease, they say, in front of them, it can still make quite a difference in terms of the amount of pain suffered afterwards. I don't think it is as effective, but it is still worth trying if that's as far as the skill set goes for that person, because they're working within their safety parameters and they, above all, don't want to cause damage. But if that turns out not to be a successful outcome, then there is usually options for referral either to another colleague within that same system or beyond. So if you're talking about the public hospital system, for example, it's often in smaller centres where there isn't the volume of work going through that there isn't enough exposure to some of the high grades of endo and things like that, then they all have a tertiary referral option to a bigger regional hospital, and you should ask for that. You should say, well, look, do I need to see somebody at Waikato Hospital, or do I need to see somebody at Auckland Hospital or Christchurch Public Hospital or wherever?
So it's about being informed and empowered and feeling confident to ask those questions, really, isn't it?
It is, and I always recommend people to take someone along with them when they go to a consultation, because invariably there's more than one person in the room on the other side of the fence, so to speak. So you can feel a bit overwhelmed. They may even just be sitting there doing not much, but they're there as another person, and you can feel silly asking questions, and you can certainly hesitate to challenge things if you think, oh no, I've tried that before, but you didn't like to say or whatever.
That's right.
But if you have someone that knows what you're going through and knows your story well, sitting alongside you, it's not only empowering, but it also helps you remember a lot more about what went on, because we all forget a lot after consultations.
Well, I often encourage patients to write things down, bullet point them and write them down, and be firm about getting the answers that they need.
No doctor worth their salt should be intimidated by a knowledgeable patient. In fact, it makes our job a lot easier if some research is being done beforehand, be it on the internet, be it through books or talking to other people, to have an understanding already about what's going on within your body and what some of the options are. It's just easier to explain things for people rather than starting afresh.
And so that really covers off the question about, the differences of opinion with, say, what you do and what other general gynecologists do. So we'll skip that and we'll hop on to the next question, which says, look, I've had lots of surgeries. Not much has helped. I still have pain on most days. What now, Dr. East?
Well, the fact that you've had lots of surgeries almost certainly means that there are other things going on. I do believe that what you take away in terms of excising endometriosis by and large stays away. And the law of diminishing returns is such that If you have another surgery, then there are less areas to take away of that internal gland wrap that I was talking about before. And so, as pain remains unresolved and continues, invariably you end up developing other reasons for having pain that confuse the issue. So most people, when they have pain on one side, for example, will lean into that side. They will change the way they walk. They will crouch over. Eventually, the domino effect of that will be that the muscles themselves involved in that abnormal posture will start to cause pain, and they will nip the surrounding nerves and they will cause pain. And because that area of the body is used to pain, the brain even starts taking more notice of that part of the body, and we call this phenomenon wind-up. And it's a true phenomenon. It's a real. The insulation within nerves is not quite as good as in the electrical wires in the house. So if there's a lot of traffic down the nerves, down the wires, then you get short circuits occurring at the level of the spinal cord, and that can cross over into the nerve supply of surrounding organs such as bowel, bladder, etc. And so you end up with this crossover between what we call the somatic system, the nerves that supply our muscles and sensory nerves in the skin, to the visceral system, which are the organs within us, and they start to dysfunction as well. So diarrhea, constipation, irritable bowel type pain, uterine cramps, increased frequency of going to the bathroom to pee, etc. So the whole thing becomes a bit of a melee of confusing symptoms, and it's about trying to help with all of those, not just automatically reach for a scalpel and say a surgery is required. And in fact, the more operations that a person has, then you get less and less benefit from a surgery, because at the end of the day, surgery is another trauma to recover from. So that leads into the idea, and it's been very well accepted now, of multidisciplinary approach to treating endometriosis, both at a preemptive level. So, for example, I tend to arrange now for a physiotherapy appointment before surgery. I started doing this over the last 6 months or so, and even a clinical psychologist seeing patients having surgery with me for the first time. It gives them the skills to help mobilize more quickly, be less fearful of the surgery, etc. But it also creates the introduction if there is more help in those areas required post-operatively as well. Well, as you know, my patients all see you as well after surgery, and that is so they have a chance to sit down and talk more widely about how they can approach life and their wellness on a more global scale, beyond the pelvis.
Living well with endometriosis.
So tackling all of these things from different angles, sorting out diet that may make the bowel feel a little bit more calm or function better, advice on bladder health, and particularly musculoskeletal intervention, and also clinical psychology intervention can be very helpful.
That really leads in quite well to the next question, which says, what do you think our government should be doing? From this woman's experience, she says that no one really seems to give a toss. Now, do you want to explain the kind of things that we are trying to do with government?
Yeah, I'll start off with not giving a toss. Look, there are a lot of people within the health sector that care. The majority of people, in fact. I think it's bad luck when somebody happens to end up in a medical environment, where they feel that they are not being taken seriously or not. It's your own responsibility to find people that do take you seriously. So don't be passive about it. If you think that you are not being taken seriously, not being listened to, there are plenty of people out there that will take you seriously. It's about finding them, it's about asking around. You can go on Endometriosis New Zealand website, and you can look for advice through there. People will give you recommendations, and find those people. That's the first thing. The second half of the question was, what should government do? Well, government does provide an excellent public service within New Zealand. It is a bottomless pit, the demands on that service. There's no doubt about that. It's very easy to be critical of the public service, but it's there by and large doing a very good job with a limited resource available, i.e. money, and where it's got to be shared around. Different groups within the health sector keep jostling for different things, so we've got to be the squeaky cog that gets the oil. We've got to stand up and we've got to shout, hey, look over here. This has been an area that's been neglected for too long. We do need more resource, but we have to compete for that with all the other squeaky cogs. We've just got to squeak a bit louder. We have been squeaking, and the Ministry of Health has been taking us seriously, and they are keen to see and to work with us, and we've been working already, to try and develop better care pathways that I'm not just talking that will be recommended for within the public system, but both public and private. You know, that a gold standard, if we can set one, is a gold standard wherever it's used. And we don't really want there to be a significant difference between those two arenas of public and private. So it's about trying to get some logic and consistency in terms of how women, patients progress through a system of care. And that's what we're working on. We're making some headway, little way off yet, rolling something out, and it'll be a continually evolving thing. You never stop in medicine. Things change, new information comes along. A practice you've tried, you might decide through research isn't working quite as well, so you evolve it. So guidelines, whatever we want to call them, pathways, people have their names, but they keep being morphed.
Well, I think it's reassuring to those listening at least that we are on the Ministry of Health table. We do have some draft, at least, of some clinical pathways in the making, and we are making sure that they understand endometriosis is a big deal, and putting some resource to that.
And it's worth saying that it's a catchphrase, or it can turn you off when you talk about sort of stakeholders, but that's what everyone involved, be it a sufferer of endometriosis, be it a care worker. We're all stakeholders in the management, and they've all been consented. So the working party consists of patients, patient advisors, people from the team of Endometriosis New Zealand, specialist gynecologists, GPs, etc. Can't think of anyone else. Can you?
Well, we were talking to Pharmac,
we had Pharmac
and
as well, which is important because there are a lot of drugs like Marina that we want to get to be available free, cheap. Cerazette, again, is another one I'd like to see funded for everyone, not just those that can afford the $70 every 3 months. So there's a lot of things out there that we want to try and harvest into this, if you like.
That's exactly right, and I think in terms of what's happening in the world in that respect, I think we're well down the track of leading, or at least being part of that crusade with working with government to make a difference. So, and I really thank you for being part of that too, Michael. It's great to have you there, and I'm sure the women will feel reassured that we have people like you on that team. You mentioned before at the start of the interview that the kind of drugs that you like to use, and so this person's saying, well, do you recommend any particular drugs for endo?
Drugs, you meaning hormone?
Hormone therapies.
Well, it's logical that we create an environment within the pelvis that has a dominant progesterone effect rather than estrogen effect. So estrogen will tend to grow the lining of the womb, the endometrium, and also endometriosis. Progesterone tends to inhibit the growth of that. So in a normal menstrual cycle, you have a sequence of estrogen production, progesterone production. When taking the combined oral contraceptive pill, It's not quite mirroring the normal cycle, but there is certainly for 3 weeks out of the 4, estrogen and progesterone exposed, and then nothing for a week. Now, that pattern of bleeding that happens very much like an ordinary cycle, that is, a bleed every 28 days, it may make endometriosis more comfortable sometimes, but it sure doesn't stop its progression. And we've seen plenty of women who've been on the pill for many, many years, relatively symptom-free, but their disease has progressed. So what we haven't got is the hard evidence that changing that environment to predominantly progesterone does hold it. But there's a lot of circumstantial evidence that it does, and there's certainly a lot of pharmacological and physiological knowledge that we have that would imply that that would be the case. So I like to see progesterone-only contraception. The better one is Cerazette over Noriday, because Cerazette stops ovulation, so you tend to get less frequent bleeding and lighter bleeding, and some don't get any. But also Mirena, intrauterine device, which has a very targeted delivery of progesterone to the pelvis and not so much to the rest of the body, so that's good for those that may suffer side effects of progesterone therapy. Most progestogens, copies of progesterone, have some male hormone side effect. Now, most women are not particularly sensitive to that, but those that are prone to acne can be. So what I've used a lot over the last 20 odd years is cyproterone acetate, which is the progestogen that is in the combined pill Ginette. So on its own, it is only licensed in this country for men with prostate cancer, so I have to explain that one quite carefully when I prescribe it. But we can take that medication, which is well tolerated for those that are prone to acne, because it will often clear their acne up, and allow them to have progesterone dominance in their treatment with none of the androgenic or testosterone male hormone-like side effects. Yeah, so it's an area that needs a lot more research. We're talking here more conjecture rather than fact, but that is why it's another reason why we want to have our own guidelines for New Zealand, because then we can monitor these things. You know, with a population the size of New Zealand, we can have a whole nation approach to management and monitor that and audit that management and learn over the next 10, 20, 30 years what is happening. You know, does progesterone-only contraception given to someone in their teens minimize the number or their risk of going on to develop stage 3 and 4 disease? We don't really know that yet.
No, we don't.
But it would be nice one day to find that out, and the only way we can find it out is to have numbers on a side.
And Professor Neil Johnson is talking later on in the month in another interview about research being undertaken in the world, so that'll be interesting to listen to too. The next thing, I'm just looking at this because somebody just popped in a question this morning, and I'm going to put it in here because it's, well, on my mind right now. She said, what are the number of surgeries you do for endometriosis each year?
Oh, God. Well, I mean, I operate about 3 times a week, and typically, and the majority of cases on those lists are patients suffering from endometriosis. So I'm doing a minimum of 10 procedures a week that relate to endometriosis, in one form or another, I'd say. I mean, I can give you an exact figure of how many I did over a 10-year time frame that I looked at all the patients that I operate on for stage 1 and stage 2 disease. So that's not all cases of endometriosis, but just those with stage 1 and 2, because I wanted to know what happened when you removed it, how many needed further surgery, and what did you find at that. So during that 10 years, there were 818 women that had surgery for stage 1 and 2 disease. So I'm guessing that there'd have been well over 1,000 in that time frame. So it's a I don't even know how that figure works out, but that figure's changed over the years. That was between 2000 and 2010, and we're seeing many more people come forward now. So a much greater proportion of my work now is endometriosis related than it was even then.
Mm. And so this really follows on from that too, because somebody was wanting to know, well, what are the statistics behind endometriosis growing back after excision? Now, I know that you know the data that you've collated here, but, can you draw on or tell us about what that is, and then what would be sort of accepted as international?
Yeah, the literature varies, as you know, and you'll see various reports between 20 and 40% chance of needing further surgery after initial surgery. That's relating to all stages. When looking at and auditing that 818 women I just mentioned over that 10-year time frame with stage 1 and 2 disease, that's what we call superficial disease. That doesn't mean to say it's trivial disease, not at all. It means to say that it's confined to the internal skin and therefore called the peritoneum. And therefore at the end of the surgery you can be pretty confident you have removed all the visible areas. And I stress visible areas. Then I can say that the chance of needing repeat surgery in my series was 12.8%. That's due to the fact that it was related to stage 1 and stage 2, also related to, I like to think I do the surgery well, but also I put a lot of marinas in, and we know that that decreases the chance of needing repeat surgery as well. But the interesting thing is what you find, because the actual figure can be debated because of people maybe being lost from follow-up or this, that and the other. But what is found can't be debated. So when I looked inside, where was the endometriosis and how much was it and who had it? So of the women that needed repeat surgery, 3/4, 75%, had endo, but 25% didn't. Now, of those that did, most of the further disease was immediately next to where we'd been before, not within where we'd been, which fits with what I said before, that what we take away stays away. It was immediately next to it, which means that it was there all along. I had missed it the first time round. Now, I don't miss it because I'm being slack. I miss it because it's not visible, because most endometriosis in those early stages is simply not visible. What you're looking at is the inflammatory reaction around microscopic disease. We know when we put the slides up of the tissue that we've removed that the bits of endo within it are too small to see with the naked eye, but we can see things wrong within the pelvis, and that's what guides us. That thing that's wrong is the inflammation around microscopic disease. Now, if there's an area that hasn't yet caused inflammation, you won't see it. And the fact that it's adjacent to the disease, it can't happen by chance, the old disease, I mean. And we have things called p-values in statistics, and the p-value for that was 0.0001, which means all the stars would fall out the sky first before that would happen by chance.
Right.
So that really does mean that it was there all along.
So one of the things I'm going to come back to... Oops, you go.
Well, I was going to say the other 25% that haven't got endo, when you look back inside, that doesn't mean they're crazy. It means a number of things. Either they have adenomyosis, which is endometriosis in the wall of the uterus, or they could have other reasons for pain. As I mentioned before, musculoskeletal causes, other reasons for having pain, even bowel function issues causing pain, that could have been pains that they recognise as being similar to what they had from the beginning, because they were all part of that mismatch at the beginning anyway, but they've been left behind. And a very common one I see is a nerve called the ilioinguinal nerve that tends to cause pain one side. It can be both sides. And that can lead to surgeries that people don't need. So it's those that we don't find endo in when we look back, they become a little bit harder to sort out, because
it does
you've
become
got to figure
complex,
out what else is going on.
And so I'm just going to ask a question that arises really from what you've just said. Could it be, particularly in those young women, that their endometriosis isn't actually visible right at the moment, but when they have another laparoscopy, say 2 to 3 years down the track, you're going to find it?
Well, it can be, but I think that I wouldn't want that to get too big a concept, really, because otherwise what's the point of a diagnostic laparoscopy? If we keep an open mind, that's the best way to put it. So if we have a look inside and the symptoms fit with endometriosis, but what we find doesn't, and I must say, by the way, that when the symptoms are there, that is particularly just that one thing that I would stress, debilitating pain with periods, then it's only about 4% of people we look inside and don't find endometriosis. So I do think that a negative laparoscopy should be taken seriously if it's being performed by someone who does a lot of endometriosis surgery and knows the most subtle appearances, the guises, if you like, that it can present, which can be missed by those that aren't doing as much in this area. It can be easily overlooked. But assuming you've had someone who is very familiar with endometriosis do the surgery and it's not found, then yes, it could be, but I think that the fact that they're presenting with pain, you'd expect something to be seen if the endometriosis was part of it. In other words, you'd expect to see some inflammation. Don't forget all those that we remove endometriosis where we're seeing the inflammation and they have come back for repeat surgery. They've usually been well after the surgery, and it takes time for those so-called, and this is a hypothesis, that the invisible endo that has yet to have inflammation around it causes symptoms. It's usually within 2 or 3 years after the first surgery, but certainly not straight away. So I think there has to be inflammation associated with endo to cause pain.
Right, so it's listening to that story really carefully. I'm going to go back a couple of questions because you mentioned the Mirena, and I just want to remind our followers or somebody who's listening to this that Michael has written a really good, easy to understand article on the Ask ESIG pages of the Endometriosis New Zealand website. And also in that same article, you updated it last year, I think, to include another follow-on about the JDS, which I think, as I recall, you called Honey, I Shrunk the Mirena. Yeah,
it's basically a smaller version of Mirena, made by the same company, the same active hormone within the capsule, if you like, in the shaft of the Mirena. Is in the JDS. It's just a slightly smaller dose that it delivers, and it lasts for 3 years, not 5. But it is designed to sit physically more comfortably, or it's the right size to fit within the uterus of women in their teens and early 20s that haven't had children. The uterus expands when a baby's put in it, as you will all know. But after the baby has been delivered, it doesn't quite shrink back to the size that it was in the teens and early 20s. And the Mirena fits and was in fact designed for that group of women, really, that have had children.
So that's an interesting article, just if people want to pop in there onto Ask ESIG and look that up.
But just to follow on from that, I've had a lot of women that have had a Mirena taken out that's mechanically causing cramps when it should help, but it's actually causing cramps. Put a JDS in, and that has suited them. So I do think size matters. Am I allowed to say that?
I think you're allowed to say that. We're all grown up. All right. So the last one really is talking about, look, here, this question says, when I go through the menopause, will my endo pain go away? It's almost a desperate plea, isn't it? You know, it's probably someone who's had pain right from the outset of their period, and here they are going through and sort of looking forward to the menopause, that they might get some relief.
Pain will go away relating to active endometriosis, because the endometriosis becomes inactive. Musculoskeletal pain that hasn't been addressed won't go away. Pain from adhesions that may have formed over the years won't go away. So it's not ipso facto that every single element of pain or discomfort will go away. Usually it gets a whole lot better. Of course, if you elect to use hormone replacement therapy because you are perhaps experiencing a very difficult time around menopause, then that can keep the whole system alive, so to speak. There are ways around that, but with what we call continuous combined therapy, and you would need to sit down and talk about that with your gynecologist or GP, and many GPs are very experienced in this as well. How to minimize HRT causing ongoing pain. Yeah.
This person's just had a scan, and how can I find for sure if it's endo? Is it just by a scan?
The majority of women that have endometriosis will have a completely normal ultrasound scan. The stage 1 and stage 2 forms will not show up on a scan. It's more like paint splatters around the pelvis in terms of amount. It doesn't show up. Basically, an ultrasound scan is a fish finder. It's a very sophisticated fish finder, but it doesn't tell us the colour of the fish. So we can't see endometriosis that's at stage 1 and stage 2. And that is the majority of women. Hopefully it is anyway, if we see them early enough. Stage 3, you may see, depending on who's doing the scan, if you have someone who's focused on endometriosis as a radiographer, they can sometimes see nodules in what are called the uterosacral ligaments. They can sometimes detect subtle changes in the ovaries, etc. So that can sometimes show up. Stage 4 disease is difficult to miss because by definition there is usually quite a bulk of tissue by then that usually can be seen. Particularly in younger women who were expecting stage 1 and stage 2 disease, the reason we're performing an ultrasound scan is to make sure that there's nothing else that could be going on. So we want to make sure that uterus is a normal shape, that it hasn't developed abnormally during their development phase as an embryo, and you can end up with a uterus that's sort of split in two, or you can have an ovarian cyst or something else going on. So it's not to diagnose endometriosis, it's to make sure that we're not caught missing an obvious something else.
So it's an information gathering tool as well, isn't it? That you want to rule out other things, but not a diagnostic tool.
And also it's a very nice way of collecting that information in the younger woman without having to do an internal examination. Because you actually get more information from the scan, and the scan is usually performed by a woman as well, and it's in a slightly different setting other than the consultation. It's just a whole lot easier.
I can remember this one coming in, which I was just about to say before, and it's coming to my mind now. Somebody alluded to, can you tell me more about the different colours of endometriosis? And I can't recall the actual question, but it was alluding to what the lesions of endo look like.
Well, in those early stages, the lesions are just the manifestations of inflammation, as I said before. The endo itself is microscopic, so what you're seeing is an increased number of blood vessels around the microscopic disease, and that's called neovascularization. And think of it a little bit like what your knee looks like when the scab's fallen off where you've grazed your knee. There's many more vessels than the surrounding skin, and that skin is often still tender if you prod it compared to the surrounding skin. So you see extra vessels, you may see a little bit of fibrosis. So part of inflammation is to produce extra fibrous tissue in the surrounding tissues, and you start to see that. And that in time, because fibrous tissue tends to shrink over time, then you start to see what we call contractures in that internal skin, or glandrap as I referred to it before, and it becomes crinkled up a little bit like the crinkled up bed sheets. So you start to see lines of tension within the peritoneum. You may see areas of hemorrhage. So sometimes as it's becoming more advanced, you may see areas of hemorrhage, and you may see the downstream of hemorrhage, which is called hemosiderin, which is breakdown products of blood, which looks like rust. You may see some tiny little cystic structures that really are tiny. That's why they can easily be missed. They're clear. The fluid within them is completely crystal clear, and these little cysts are less than 0.5 millimeter in diameter, and you can see those sometimes. We call them vesicles on the surface of the peritoneum. You can often see little areas become a little bit lumpy as the fibrous tissue starts to develop, and you may get hemorrhage into those and what are called blue dome spots. They're the more classical appearance of endometriosis that's been described for a long, long time. The more subtle findings we've really only known since advanced laparoscopy came along and been able to get very close with high-resolution cameras to things. So, and then of course as it develops, you may get big cysts on the ovaries, you may get structures stick to each other like the rectum stick to ovaries or ligaments in the pelvis.
Michael, I can't thank you enough for, the others won't know, but I'll let our followers know that this is a Saturday morning. Actually, Saturday morning has become Saturday afternoon. Thanks so much for giving up your time. I think, too, for our people to know more about you, you've been involved with Endometriosis New Zealand for many years and are now remain on the Endo Special Interest Group, or ESIG as we call it. We greatly appreciate your interest in the disease, your expertise and the care that you have for the better health of women and girls with this condition. So thanks a mil for being here, for giving up your time. We really appreciate what you do.
It's a pleasure.
One of the things that we'd like to remind you about is this book, which is a wonderful resource for you to have, Endometriosis and Pelvic Pain, by Dr. Susan Evans from Adelaide, Australia, and I'm a co-author. One of the things that we just wanted to make sure is that you know that all sales of the book in New Zealand go to Endometriosis New Zealand, so all royalties. I think that's really important. But more important is the fact that every chapter is standalone. You'll be able to find out things about diet and nutrition and bowel symptoms that sometimes cause that irritable bowel that many of you suffer from. What about when sex is painful? So there's a chapter on that, on coping strategies, on teenage girls with endometriosis. It's a pick up, it's a put down, it's something that a lot of women tell me they have by the bedside, and they often highlight all the bits so that when they're going to their doctor, they can do the resource check with them to make sure that they're getting the best management for the care that they need. So just remember, endometriosis and pelvic pain, available through Endometriosis New Zealand. Check out the resources on the Endo NZ website.